You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for April 8th, 2022. This is part one of the ACC recap. First of all, it was nice to be at a major meeting that was held at least partially in person. Now, I've been to two smaller meetings in the last 6 months, but ACC was the first major meeting. The two American meetings in cardiology, ACC and AHA, have been known for their largeness and big crowds. That was definitely not the case in D.C. Even in the smaller Washington, D.C. Convention Center, the attendance seems sparse. You notice this especially when you're walking through the expo. But it is a start. There were hugs, and that is good. So good. Okay, let's move on to the science. I won't get to all of the studies this week, so we'll do some next week as well. Perhaps the most important study first, hypertension in pregnancy. The chronic hypertension in pregnancy, or CHAP, trial is a very important trial presented at ACC and published in New England Journal of Medicine, and it addressed the treatment of hypertension in pregnancy. A couple background nuggets. Chronic hypertension affects about 2% of pregnancies in the U.S., and it disproportionately affects Black women. Hypertension ups the odds of bad things for babies and moms, preeclampsia, placenta abruption, small birth weight, and also maternal death, heart failure, and stroke. Now, treatment of hypertension in pregnancy is controversial. There is consensus to treat pregnant women with severe hypertension, but for women with mild chronic hypertension, say less than 160 over 110, it is unclear whether to withhold antihypertensive medications until the increase in blood pressure is severe or to continue the patient's previously established therapy. The CHAP trial looked at women with mild chronic hypertension. About 2,400 women, one group called the active treatment arm, had a goal blood pressure treatment to get below 140 over 90. The control arm would have no treatment unless the blood pressure went above 160 over 105. The treatment arm was with labetalol or nifedipine ER, and then titration to the goal of less than 140 over 90. The control arm was no treatment unless the blood pressure was greater than 160, and if so, the goal was then less than 160 over 105. The primary outcome was preeclampsia, medically indicated preterm birth less than 35 weeks, abruption, fetal, or neonatal death. The safety outcome was small for gestational age birth weight below the 10th percentile for gestational age, and secondary outcomes included composites of serious neonatal or maternal complications, preeclampsia, and preterm birth. Okay, the results. For the primary endpoint, 30.2% versus 37% favoring the treatment arm. The hazard ratio was 0.82, so an 18% reduction. The confidence intervals range from 0.74 to 0.92, and of course, this is highly significant. For the components of the primary, preeclampsia was 20% lower, preterm birth was 27% lower, and both were significant. For the safety endpoint of small for gestational age, there was no significant difference. There was also no difference in maternal complications or severe neonatal complications. Now, there's two important limitations. One, it was open label, so there's always a chance for performance bias. Also, the investigators screened 12 patients to enroll one. Now, nonetheless, I see these as the clearest results of the meeting. In pregnancy, it's best to treat mild hypertension to a goal of less than 140 over 90. This could have massive health benefits and improve our maternal and neonatal health in the U.S. And I say congratulations to the investigators and also to the NIH for funding such an important trial. The next trial is POISE 3. New England Journal of Medicine published a trial comparing tranexamic acid to placebo in non-cardiac surgery. Tranexamic acid is an antifibrinolytic drug, and it is approved for heavy menstrual bleeding and short-term prevention in patients with hemophilia. It is used off-label and has been shown to reduce bleeding after C-section and cardiac surgery. Small trials have suggested benefit in orthopedic surgery, but no big trials have been done in major non-cardiac surgery. So, the research group at McMaster's undertook POISE 3, which is a large placebo-controlled trial in 114 countries on 6 continents, more than 9,000 patients, age 69, who are at risk for bleeding or cardiovascular complications. And all sorts of surgeries were included. General, ortho, vascular were the top 3. The endpoints were interesting and different than usual. Bleeding was the primary endpoint and was tested for superiority. Myocardial injury, stroke, systemic embolism, or DVT, or clotting ischemic factors, was the safety endpoint, and it was tested with non-inferiority. And that makes sense, right? You want to establish that the drug is superior in preventing bleeding, that's what it does, but not worse than nothing in creating events caused by clotting. Now, the non-inferiority margin of the safety endpoint was set at 1.125. That means if the upper bound of the confidence interval, the rate of thrombotic events, was more than 12.5%, non-inferiority would not have been met. So here are the results. It was better for bleeding, tranexamic acid 9.1%, placebo 11.7%, hazard ratio 0.76, so that's a 24% reduction. Confidence intervals 0.67 to 0.87, so that's highly significant result for superiority and reduction of bleeding. But for safety, it was interesting. 14.2% tranexamic acid, 13.9% in placebo, hazard ratio 1.02, so it seems like the same. But with non-inferiority, you have to consider the 95% confidence intervals, the upper bound specifically, the worst it could be. Here, it was 0.92 to 1.14. Since that upper bound of the confidence interval was 1.14, and that's greater than the non-inferiority margin of 1.125, non-inferiority was not met. The translation here is that the drug really reduces bleeding, but non-inferiority was not met. Now, previous cardiac surgery trials of tranexamic acid has shown higher risk of seizures. The authors write, this was found to be dose-dependent effect. So in POISE 3, they used 2 doses of 1 gram of tranexamic acid, and at doses of less than 2 grams, seizures are less common. And indeed, that is what they found in the trial. In POISE 3, the incidence of seizures was 0.2% versus less than 0.1% in placebo, and that they felt was non-significant. Okay, so my comments. You have a highly clinically significant and statistically robust decrease in major bleeding, but it's balanced against a very, very small increase in thrombotic events. The author suggests considering bleeding risk. They've even published a bleeding risk calculator. Here is what they wrote. 3 things. Patients prefer to avoid bleeding and transfusions, and although tranexamic acid can facilitate these goals, only a small proportion of patients undergoing non-cardiac surgery currently receive it. There is an annual global shortage of 30 million blood product units, and surgical bleeding accounts for up to 40% of all transfusions. And given that 300 million surgeries occur annually worldwide, the results of the POISE 3 trial indicate the potential for large public health and clinical benefits if tranexamic acid becomes standard practice in non-cardiac surgery. And of course, I see their point. This is a tough call. I tend to agree with them. The problem, of course, is that the risk factors that make one at higher risk of bleeding often overlap with thrombotic events. But on the other hand, the rate of thrombotic events barely missed non-inferiority, so the signal was low. In fact, in the presentation, they write that there's a 95% probability that the hazard ratio is actually less than 1.12. And, of course, remember that non-inferiority margins are not set in stone. Had the non-inferiority margin here been just a little bit higher, we'd be declaring, yes, tranexamic acid is a huge win. Now, if any listener has more experience with these drugs and feels strongly, please leave a comment on the heart.org Medscape Cardiology webpage. All right, third topic, hypertrophic cardiomyopathy. ACC brought potential good news for patients with severe hypertrophic cardiomyopathy. Now, this drug has a funny-sounding name. It's called mavacamten, and it is a myosin inhibitor drug that decreases sarcomere power. And previous studies with this drug have shown that it reduces LV outflow tract gradients, it improves functional capacity, and reduces symptoms in patients with HCM. The trial presented at ACC, called VALOR HCM, enrolled patients who had hypertrophic cardiomyopathy who were referred to big centers for septal reduction therapy with either surgical myectomy or septal alcohol ablation. So these patients had very severe hypertrophic cardiomyopathy. The primary endpoint of VALOR was avoidance of septal reduction therapy. It was mavacamten versus placebo for 16 weeks. And the results strongly favored mavacamten. Only 18% of the mavacamten arm met the primary endpoint versus 77% of the patients in the placebo arm. The absolute risk difference here was 59 percentage points. Now, the driver of the composite endpoint was no longer meeting septal reduction therapy eligibility, and that could be either by symptoms or LV outflow tract gradient reduction. The drug also performed well in clinical and echo parameters such as improvement in one or more New York Heart Association functional classes, resting and Valsalva LV outflow tract gradients, and cardiac biomarkers. The adverse effects were minimal. So my comments. Hypertrophic cardiomyopathy is certainly not as common as coronary disease or heart failure with reduced ejection fraction or atrial fib, but it is not uncommon. And when the gradient gets this severe, patients have no good non-invasive options. And the septal reduction therapy is pretty morbid. Surgical myectomy or creating MI in a septal coronary artery, these are not small things. If a pill reduces gradient and helps patients feel better and avoid surgery, I see this as a big gain. Now, there are a few caveats here. We have only 400 patients in trials who have been studied with this drug in quite short duration trials. We need more safety data. Myosin inhibition is essentially a negative inotrope. Now, will it increase the risk of arrhythmia, for instance? We don't really know from these sorts of studies. And another issue will come to be translation in practice. The trial was conducted at centers of excellence, and the protocol of VALOR required frequent echoes and then dose titration depending on the echo parameters. I doubt that this can be simulated in real-world practice. What's more, the FDA is meeting on this drug later this month, and if approved, there will be tremendous amount of excitement and marketing, and there will be a temptation to use it in patients with less severe disease who were not enrolled in trials. Now, the other thing that bothers me is that VALOR HCM had a massive effect size. Okay, the drug could be this good, but I wonder about blinding because patients in the drug arm had lots of dose titrations. Could they know that they were on a drug? And we know from empirical meta-studies that studies with large effect sizes often stem from small studies and then aren't replicated in larger studies. But I am cautiously optimistic that possibly, maybe, we have developed a new class of agents that have disease-modifying properties in hypertrophic cardiomyopathy. There is, in fact, another myosin inhibitor drug that looks promising in phase 2 studies. So stand by for more information on this drug, but it's exciting. Next topic is percutaneous left atrial appendage occlusion. There was news on percutaneous left atrial appendage occlusion from ACC, and it was not encouraging. Now, before I start, I want to say a word on the modifier percutaneous before left atrial appendage occlusion. It's important to distinguish between percutaneous appendage closure and surgical closure. Percutaneous closure is what cardiologists are doing, and it entails placing a foreign body in the inside of the left atrium that then is exposed to the arterial side of the blood. Surgical closure is done epicardially by surgeons. Percutaneous closure has dubious data. Surgical closure at the time of surgery for something else has very strong data, that is the LAOS 3 trial. Okay, back to ACC and percutaneous closure. A group led by the Mayo Clinic team queried the mandated NCDR left atrial appendage U.S. registry. and they identified more than 55,000 patients who had had Watchman implanted over a 3-year period. Now, based on TEEs at 45 days, they identified 3 groups of patients: those who had no leak, peri-device leak, those who had small peri-device leaks less than 5 millimeters, or large leaks greater than 5 millimeters. Now get this and pause for a second. They found 1 in 4 patients, more than 13,000 patients, had small peri-device leaks. 1 in 4. And these leaks associated with a statistically significant 15% higher rate of stroke, TIA, or systemic embolism, and an 11% higher rate of major bleeding. Okay, that's the first study. There were 2 other posters at ACC addressed the issue of who is getting this Watchman procedure in the U.S. One poster, which I was a co-author on, it was led by groups at the University of Florida and Penn State University, used Medicare claims to compare the baseline characteristics of patients who have Watchman in the real world versus those who were enrolled in the pivotal trials Protect and Prevail. Another poster from the Beth Israel group, led by Robert Ye, used Medicare data to assess the frailty scores of patients who get percutaneous occlusion in the U.S. Both posters found extremely sobering data. We found that patients getting Watchman now are older and have many more comorbid conditions than those enrolled in the pivotal trials. The Beth Israel group in Boston found that nearly half of all Watchman implants are done in patients with some degree of frailty. Now, these 2 posters are scary because older, sicker patients are least likely to benefit from percutaneous closure. A, because they have oodles of competing causes of stroke, and B, they will have a higher procedural risk, which studies have already shown is in the 6 to 10% range in real-world data. So in sum, my friends, percutaneous closure struggles to actually occlude the appendage, right? We have peri-device leaks. This is bad because small leaks can increase thrombotic and bleeding risk. And American doctors are increasingly doing these procedures in patients least likely to benefit. I remain extremely negative on this procedure. I think it may be one of the biggest mistakes cardiology makes in a generation. All right, next topic, salt restriction for heart failure. For my entire career, I've seen patients with heart failure be told to eat a low-salt diet. Many clinicians get extremely aggressive with this recommendation. At the American College of Cardiology meeting, Dr. Justin Ezekowitz from the University of Alberta in Canada presented results of the sodium HF trial, which put this common recommendation to the test of randomization. The paper was simultaneously published in Lancet. Now, I did not actually know this, but before sodium HF, there was little to no supportive evidence for a strict low sodium diet. Studies were small, and when taken together, they failed to show any significant signal of benefit. Yet, like so often happens in medicine, the dogma persisted until now. Sodium HF is a pragmatic randomized controlled trial that tested general advice on dietary sodium against a very low sodium diet of 1,500 milligrams per day. It was done in 26 sites in 6 countries, and the investigators tailored the diet to that area or region. Now, an important note on the trial arms. Sodium HF did not study a willy-nilly typical American high-salt diet versus a salt restriction. It studied general advice on avoiding salt versus a specific diet designed to get down to 1,500 milligrams per day. And a word on pragmatic trials. Unlike drug trials, which can be strictly controlled, active and treatment arms in relatively optimal setting, pragmatic trials test interventions in the real world, and that difference influences how we should interpret and apply pragmatic trials. Patients in sodium HF had class 2 to 3 heart failure, age 66, average EF of 36%, were on good baseline medical therapy. The average sodium intake, as measured by 3-day food records, was approximately 2,000 milligrams per day in the control arm and about 1,600 milligrams per day in the low sodium arm. So not much difference there. The primary outcome occurred in 15% of the low sodium arm versus 17% of the control arm. The hazard ratio was 0.89, and it did not even come close to meeting statistical significance. Death, CV hospitalizations, CV emergency department visits did not differ significantly between the groups. And patients in the low sodium arm scored significantly better on the KCCQ questionnaire, which measures a person's perception of their health. And the authors concluded beautifully with just one spin-free sentence, quote, "In ambulatory patients with heart failure, dietary intervention to reduce sodium intake did not reduce clinical events." Now, my comments. I love this trial. First of all, the authors did not spin this non-significant primary. There was no language designed to detract from the non-significant primary endpoint. There was no pre-COVID analysis or, hey, look at how great this subgroup did shenanigans. So I have to admit that my highly positive interpretation of this trial may have been driven by the scientific humility of the research team. It was enthralling. Now, the biggest criticism of this trial was that the control group did not eat a lot of salt, and thus the difference in salt intake was only about 400 milligrams. The thinking being that that isn't enough to drive lower CV events and heart failure admissions. Had the control group been more like the typical American high salt diet, then maybe the 1,500 milligram per day sodium diet would have worked. But my counter to that argument goes back to the study arms. Sodium HF did not test no advice versus a severely restricted sodium diet. It tested normal advice to avoid high salt foods versus a strict diet. The translation of that is that we don't have to waste time getting patients down to a super low sodium diet. And I think that's huge because one of the core challenges of caring for patients with heart failure is to decrease their work of being a heart failure patient. As I wrote in my column on this trial, patients have an adherence bank, right? If you limit the low-value stuff that they have to do, they're more apt to do the important stuff, like take their medications and perhaps exercise. All right, a couple short reviews and then I'll quit because I've already been going on for a while. Flu vaccine and heart failure. The IVVE trial studied flu vaccine to placebo in patients with heart failure in Asia, the Middle East, and Africa over 3 flu seasons. And there was no significant difference in the primary outcome of CV death, MI, stroke, or heart failure hospitalizations. Some of the secondary analyses were positive. For instance, flu vaccine reduced CV outcomes during peak influenza period, and it reduced pneumonia admissions. But you know how I feel about secondary outcomes when the primary is negative. Spin gives me a rash. Now, this is a different finding from the positive IAMI trial, which studied flu vaccine in early post-acute MI patients and found a significant reduction in CV events in the vaccine arm. Now, maybe heart failure patients aren't quite as tenuous as post-MI patients. Maybe many placebo patients in the more recent trial took the vaccine outside of the trial. But here's the thing. I'm not sure we need any more trials looking at flu vaccine in older patients with comorbid conditions. To me, it doesn't matter if it reduces CV outcomes. If it reduces flu severity, pneumonia, or hospitalization, that seems like enough to me. Older and vulnerable patients have oodles to gain from vaccinations against a common and serious respiratory virus, and we should encourage our vulnerable patients to get their flu shots. Finally, factor 11 inhibition looks promising. Dr. Manesh Patel from the Duke Research Institute presented early data on a new antithrombotic drug that may someday replace DOACs. It was called the Pacific AF study, and it was a phase 2 study. The drug is called asundexian. It is an oral drug and a small molecule inhibitor of activated factor 11. The key paragraph from the amazing journalist Sue Hughes, quote, activated factor 11 is thought to contribute to clot progression, but in contrast to other clotting factors, activated factor 11 has only a minor effect on clot consolidation during hemostasis. Now, I'm not going to say any more because it is too early to say anything more. Just know that we might someday have a better direct-acting oral anticoagulant. But worry not, it won't likely diminish enthusiasm for putting things in the left atrial appendage. Okay, my friends, I've done 7 topics, and let's stop here and continue next week. Also, the European Heart Rhythm Association meeting in Copenhagen happened at the same time as ACC, which is sad, but it did. I will take a look at some of the studies there and report back. And also, FDA approved another leadless pacemaker, this one from Abbott, and it has a screw-in mechanism rather than tines, and we shall see if it is any better than the current version than we're using now. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, it really helps if you could give us a rating, write us a little review. This helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.